Good morning. Little housekeeping here. We just want to make sure that everyone's comfortable. If you are cold, would you raise your hand, please, so we can adjust the temperature accordingly? Okay, I know. Okay, thank you. So we will begin with section GG, Functional Abilities and Goals. And this is a great section for occupational therapists here in my former life. And really excited about presenting this to you. We've had so many interesting questions that come along on Help Desk that help guide us in terms of further clarification. So we'll get started here. Okay, we first present the acronyms for this section. You have a collection of acronyms now that you have at your disposal. I think we recommend keeping your guide as reference in terms of for this section as well. So our overview of what we'll present today is we'll explain the intent of section GG, the functional abilities and goals. We'll also review the changes between the LTCH Continuity Assessment Record and Evaluation Set, that's your LTCH CARE Data Set, between version 3.0 and now the coming version 4.00, which will then be applicable for your data set items that you'll be recording in 2018. Discussion of coding instructions and the needed information, of course, for these items. And then we'll have an opportunity to review and practice using coding for various scenarios that we've prepared. So our objectives are to describe the intent of the changes that have been made from version 3.00 to 4.00, section GG, and explain the clarifications for those item definitions. We'll apply coding instructions to accurately code practice scenarios. So our intent is that we know that many patients in long-term care hospitals have self-care and mobility limitations, and most are at risk of further functional decline and complications for limited mobility. And we know from the research that literature that in better health and functional outcomes are seen in patients that self-mobilize during hospitalization and post-acute care, to the extent that their conditions allow, that is. Activities such as walking as part of self-care activities are extremely important for improving outcomes and, of course, recovery from ill health. So let's take a look at these changes that were made between these two versions, and we'll be reviewing these during the presentation. So some of these changes you heard yesterday, we did a little bit of discussion about and previewing what they would be. So again, I'll repeat that we have an additional code, which is 10, not attempted due to environmental limitations. But I will state that since this is these are standardized assessment data elements and the coding is included here, that we don't anticipate for LTCHs that you'll have need to use this code, but we just want to introduce it. Other settings that have other items in their data set might be using this code, but we don't anticipate LTCHs to do so. Item definition clarifications will be included with that additional and/or for select items. We'll cover that, and we'll walk the walking item skip pattern. We'll be talking about that as well. So let's look at some of your coding guidance and practice scenarios here. So just to give you the lay of the land here, you can see that GG0130, prior functioning everyday activities, are going to be assessed on admission. And GG0110, the prior device use, that's also only assessed on admission. And the GG0130, self-care, are assessed on the admission and the planned discharge assessment. And the mobility GG0170 group of items will be assessed on admission as well as on your planned discharge assessment. So GG0100, prior functioning everyday items, applies, again, as I mentioned, to the admission assessment only. This is what it looks like. You only have, for the LTCH CARE Data Set, one of these items. And the item for mobility, which is on the LTCH CARE Data Set, that gives us the knowledge of the patient's functioning prior to their current illness, exacerbation, or injury. And this may help us inform treatment goals. So it's very important to acknowledge the fact that this is their prior functioning. This is not their current status that we're looking for here. So how do you find this information? What are the steps for assessment? You'll interview the patient, or if it's applicable, the family. You'll also be reviewing the patient's medical records, which describe the patient's prior functioning with everyday activities. In this case, it's for the mobility item. And here are your coding instructions for this specific item. So you'll select between the following codes, and notice that for this item, GG0100, there are specific codes. Code 3 is for independent, if the patient completed the activities by him or herself with or without an assistive device, with no assistance from a helper. Code 2 is needed some help if the patient needed partial assistance from another person to complete activities. And code 1 is dependent if the helper completed the activities. In this case, we're speaking about mobility. And so that would be if somebody is required in terms of pushing their wheelchair. For code 8, unknown, for this, it's if the patient's usual ability prior to current illness or exacerbation is unknown. You do have some few days to be able to gather this information, so we would hope that you would do so. Code 9 is not applicable if walking or mobility, if mobility in this case was not applicable to the patient prior to current illness or exacerbation or illness. So these coding tips that we bring to you here include recording the patient's usual ability to perform indoor mobility or ambulation prior to the current illness or exacerbation or injury. And if no information about the patient's ability is available after attempts to interview the patient or family, and after reviewing thoroughly the patient's medical record, you would code 8 unknown. If the clinician does not attempt, for whatever reason, to gather this information, then you would use the dash for this item, and of course CMS expects dash use to be a rare occurrence. So GG0110, prior device use, applies to the admission assessment only. And here's what it looks like. You can see that it's a check all that apply list. The rationale for use of this item, again, is for our knowledge as to what devices the patient may be using or aids immediately prior to the current illness, exacerbation, or injury. And again, it may inform your mobility treatment goals. And your steps for this particular item is, again, to interview the patient, talk with the patient. If they're not able to give you that information, you may have access to the family or significant other and review the patient's record. It may be in the record describing the patient's prior use from the former facility the patient was at. In coding GG0110, again, you're only completing this at admission, and you will check all devices in this case that apply. So it's a check all that apply list, whether it be manual wheelchair, motorized wheelchair, and or scooter, or a mechanical lift. And if you check Z, it's because that none of the above are applicable. And this patient did not use any of these devices prior to the illness, exacerbation, or injury. So here's our item set for the GG0130 self-care. You can see that we've exhibited here the admission assessment, what that would look like in terms of the 4 items, and then you can also see the planned discharge assessment. Notice that the admission assessment includes your discharge goals, and those are assessed upon admission as well. So what are your steps for determining what the coding would be in this section? So we say that a licensed clinician may assess the patient's performance. We get a lot of questions about who can perform. So we're saying that it's a licensed clinician, and they will assess the patient's performance. This will be based upon direct observation, preferably, and input as well from patient's self-report, if that applies. And you can also certainly gather information from other clinicians, other care staff, or family members during that 3-day assessment period. So, and patients should be allowed to perform as independently as possible. We want to give them that chance in terms of being able to get their baseline, as long as they are safe. If a helper does assist the patient because of patient safety concerns, if they're unsafe, or it's of poor quality and we want to ensure that they complete the necessary item, you should code according to what amount of assistance is required for that item. So other steps in this assessment would be the activities may be completed with or without an assistive device, and the use of the device should not affect the coding of the activity. Okay, so someone can be independent with or without use of a device, and the determination of whether to use that device, we should consider safety in terms of that aspect. If the patient's self-care performance varies during the assessment period, report the patient's usual status during that 3-day assessment period, not the patient's most dependent episode. So that's an important factor here. You also should refer to the facility's federal and state policies and procedures to determine which of your LTCH CARE staff members may complete the assessment. As we mentioned before, patient assessments are to be done in compliance with your facility and federal and state requirements. So we're going to go over the coding instructions, and these coding instructions include if the activity was not attempted during the 3-day assessment period, and so we have indicators as to why that did not happen. You would use, of course, 07 as you have been if the patient refused, code 09 for not applicable, and the code 10 we talked a little bit about that before, that we don't anticipate that LTCHs will need to be using that code. And then there's code 88 for not attempted due to medical condition or safety concerns. So let's take a look at how you would go about determining these codes. Some of you may be new to this area, others have been coding this section for a while, but we know that those teaching elements are important for you in terms of discussing these and reviewing these with your staff. So let's start with this. We're going to go through a series of questions that will help you determine the degree of assistance the patient requires to complete the activity. So the first thing we're going to ask, as you see in the blue diamond, does the patient complete the activity by him or herself with no assistance? And by no assistance, we mean no physical, no verbal, no nonverbal, cueing, setup, cleanup, any of those. And if you answered yes, then you would code 06, independent. But if you answered no, you'd further proceed to this next question. And you would begin by asking, does the patient or resident need only setup or cleanup assistance from one helper? If the answer is yes, then you would code 05 for setup or cleanup assistance. Remember, that means that you are not present during the time of the activity. This is a before or after assistance, that setup or cleanup assistance. If the answer is no, then you would continue to proceed to the next question. In the next question, we ask, does the patient or resident need only verbal, nonverbal cueing, or steadying, touching assistance from one helper? If the answer is yes, then you would code 04, supervision or touching assistance. Sometimes people in therapy call that touching assistance contact guard assist. We also call that steadying assist. So if the answer is yes, you code 04. If no, then you'll go to the next question. And we would ask, does the patient or need lifting assistance or trunk support from one helper, with the helper providing less than half the effort? The important distinction here is less than half the effort. So you have to determine and consider all tasks that are part of that activity, and then determine how much the total assistance was required from the helper. So if the answer is yes, you would code 03, partial moderate assistance. If the answer is no, you would then ask the next question. Does the patient need lifting assistance or trunk support from one helper, with the helper providing more than half the effort? And again, the important distinction is more than half the effort. Again, you would consider all the tasks that are a part of that activity and then determine how much assistance is required from the helper. And if the answer is yes, you would code substantial or maximal assistance. If the answer is no, you would go on to the next question. Next, you'd ask, does the helper provide all of the effort to complete the activity, or is the assistance of two or more helpers required to complete the activity? If the answer is yes, you would code 01, dependent. And even if the patient offers a little effort with those two or more people assisting, you would still require a 01 dependent coding for that patient. Okay, so now let's take a look at how we would code if the activity was not attempted. So why was the activity not attempted? With code 07, patient refused, we use that code if the patient does not attempt the activity and a helper does not complete the activity for the patient for the entire 3-day assessment period. That's very important. So you code the reason the activity was not attempted as 07. So for example, for code 07, if the patient refused to attempt the activity during, again, the entire 3-day assessment period. So we wanted to note that for code 09, not applicable, we've added a clarification. So for code 09, not applicable, we've added the following clarification. If the patient does not attempt to perform the activity and did not perform the activity prior to the current illness, exacerbation, or injury. So that is when you'll use this code 09, just to clarify. And then we talked about the newly added code 10, not attempted due to environmental limitations. Again, we don't feel that any of the items in your item set for the LTCH CARE Data Set would apply for use of this code. Code 88, we haven't changed anything there. If you're using this, if the patient, the activity was not attempted due to medical conditions or safety concerns. Okay, so let's look at some general coding tips. So again, this is the 3-day assessment period for the admission assessment, and that means it includes the day of admission and the 2 days following the day of admission, and it ends at 11:59 p.m. of the last day, the 3rd day. So during the assessment time frame, some activities may be performed multiple times, but others may only be performed once, and some not at all. So we ask you to take a look at that 3-day period and determine when that patient had attempted that activity. So clinicians should code the patient's admission functional status based on a functional assessment, and it should occur as soon after the patient's admission as possible, because we want to capture what the patient's baseline was prior to any benefits of therapy. And so this is important, because then it allows us to really get the idea of what that patient's best baseline was. So further with coding tips, we anticipate that a multidisciplinary team of clinicians will be involved in assessing this patient in 3 days. And that's an important concept for folks to grasp, because that enables you to get a number of perspectives and views of the patient's performance abilities during that 3-day period. So if you yourself are the one who's coding, you may need to rely on some of these other staff members who have cared for the patient. So a licensed clinician may assess the patient's performance, and we of course prefer direct observation, and but you can also add to that with patient self-report if that person is cognitively intact, and reports from, again, those other clinicians, those other staff members that care for the patient or family during that 3-day assessment period. And to clarify your own understanding of the patient's performance, you may still want to ask direct staff some of these probing questions to get more information to determine what you feel the baseline coding for that patient would be. And patients with cognitive deficits may need physical and or verbal assistance when completing an activity. So be sure to code those patients based on the patient's need for assistance to perform the activities safely. For example, a patient may have a choking risk that has cognitive deficits as well. In eating, amount of the food placed in the mouth might be something you have to cue or drinking. They also may have a higher risk of falling when completing some of their upper body bathing in bed even, or other times. So it's important to really consider and be patient-centric in your assessment. Now, a dash sign indicates that no information from a patient is available, and CMS expects a dash to be used in a rare occurrence. The use of dashes for items necessary to calculate the quality measures may result in a 2% payment reduction to the LTCH's annual payment update, the APU. So we want to keep that in mind, and that's why, again, trying to avoid that if it's at all possible, and find the information that's needed. So we don't want you to use a dash if the reason that you are coding it as such is because the patient refused. If the patient refused, then it is a code 07. And if the item is not applicable, of course, you would code 09. And if the activity was not attempted due to medical condition or safety concerns, then you would code 88. And notice I skipped intentionally code 10 here. So just remember to talk with the staff directly and to gather as much information as possible so that you can avoid no information to report. So on the admission and the planned discharge assessment, you're going to be coding the patient's usual performance using that 6-point code scale. And the reason an activity was not attempted as well. Do not record the patient's best performance, we want to emphasize, but rather record the patient's usual performance during that 3-day assessment period. And you want to ensure that you're coding the patient based on their actual performance, not what you think that they can perform, but actually what they do perform. We have patients that we might feel are not putting their full effort in and want to feel like we are giving them credit for something we think that they can do, but we should not do that. We should do it directly from what is observed and what information we get about the patient. That's very important. So if an activity can't be completed or if an activity can be completed with or without a device, that is a call in terms of the clinical judgment that you use. If a patient has been, however, using an adaptive device or a piece of equipment independently, then go ahead. The patient should use that piece of equipment, and they can be coded as 06 independent. If the helper needs to retrieve any device or any kind of adaptive equipment for that patient in order for them to perform that activity to the best of their ability or for safety concerns, then you would use the code 05 setup or cleanup, and that is, again, something that you provide in terms of assistance before the activity or after the activity. But it means that you did not have to be present for any reason during the activity. So what do you do if a patient experiences an unplanned discharge or a patient dies during the LTCH stay? Discharge GG0130, sorry, there's a typo there. Self-care data are not coded. Okay, so GG items are not included on the unplanned discharge assessment or the expired assessment. So this is after you've already done the admission assessment, and now something occurs where the patient has an unplanned discharge or dies. When you pick up your unplanned discharge assessment or expired, you will not see those items because it is not expected that you will have to code them, relieving you of some burden there. So let's take a look at the first item, which is GG0130A, eating. And again, this applies to both the admission and the planned discharge. So this is what it looks like. It's the first item that's going to be in your item set. And the definition of GG0130A, eating, has been clarified. So we've added to that and or liquid. Let's read it through. The ability to use suitable utensils to bring food and or liquid to the mouth and swallow food and or liquid. And again, it's still once the meal is placed before the patient. So let's start our first practice coding scenario. Right? So before we start, let's make sure that everyone has their polling device in front of them. Have you delegated someone at the table to be the spokesperson after you talk amongst yourselves and decide on a code? Okay, so let's get ready. Okay, so Ms. S does not eat or drink by mouth and relies solely on getting nutrition and liquids through tube feeding due to a recent onset stroke and swallowing disorder. The tube feedings are administered by the staff at this time, but the goal is that Ms. S and her 2 daughters will learn how to administer the tube feeding before discharge. So here are your choices. How would you code this item? Would you code it 02, substantial maximal assist? Would you code it 09, not applicable? Would you code it 10, or would you code it 88, not attempted due to medical condition or safety concerns? So we'll let you folks think about this and then enter your response. Okay, looks like everyone's got their response in. Okay, so we have a number of different responses here. Code and 47% for code B, not applicable, was in there, when in fact it was code D, 88 not attempted due to medical condition or safety concerns. So this gives us a real opportunity, and this is obviously a great one to go through with your staff in terms of distinguishing between the difference between 09 and code 88. So let's look at our rationale, and this is what you would want to emphasize during your training of your staff, that coding GG0130A, eating, would be coded as 88, not attempted due to medical condition or safety concern. And the rationale for this is that eating and drinking was not attempted due to a recent onset stroke and swallowing disorder. Administration of tube feeding is not considered when completing the activity eating. So this is very important, that this was due to a recent onset. Okay, this was not an existing condition. And that if it was an existing condition, then that would be a different code, right? So that would have meant that the person had this condition before and prior to admission, prior to this recent onset, this person had been having the same issues. But this was a recent onset, so clear about that. And now let's go to coding scenario 2. Mr. R eats and drinks by mouth, but his intake is not adequate due to recent gastrointestinal surgery. Mr. R relies partially on nutrition and liquids via tube feeding. The staff administer Mr. R's tube feeding when eating and drinking by mouth. Mr. R requires steadying assistance from a helper due to his hand tremors. So let's take a look at your choices here. Would you code 04, supervision or touching assistance? Code 3, partial moderate assistance. Would you code 02, substantial maximal assistance, or 1, dependent? Let's see what you come up with. Okay, looks like we have more people responding. Give them a couple minutes, a couple seconds. Okay, let's see what you come up with. Okay. We have 62% who said supervision or touching assistance. We still had 31% who felt that was partial or moderate assist, and 8% who thought it was substantial. So let's look at what the answer was. It was the majority got this right with 04. Let's take a look at what the rationale was here. That why you would code this 04 as supervision or touching assistance. And the reason why is because when we looked at this item, we were looking specifically at what amount of assistance that patient needed. And in our scenario, we talked about how the patient needed steadying assist. So that word, steadying assist, or observation of someone needing steadying assist, is key here. when the person was eating and drinking by mouth. And the assistance with the G-tube feeding, it was not considered when coding this item. So steadying assistant equals 0.4. So that's one of those teaching moments, again, that you want to emphasize with your staff. So let's go through oral hygiene. And you can see what it looks like in terms of the item. It's the second one for GG0130. The definition of GG0130B, oral hygiene, has been clarified. So we now say the ability to use suitable items to clean teeth, dentures if applicable, the ability to insert and remove dentures into and from the mouth, and manage denture soaking and rinsing with use of equipment. So we just made a bit of clarifications. It shouldn't change the way you normally would code this. The wording just has been changed when describing the steps for this dental hygiene, and that's it. So let's try this out in a scenario. So Mr. W is edentulous, meaning without teeth, and his dentures no longer fit his gums. Mr. W has several upper extremity joint contractures, and this impacts his fine motor skills. And Mr. W uses a soft toothbrush to clean his lower gums and starts to clean his upper gums. The helper cleans the upper gums in the back, as it is difficult for Mr. W to reach. Mr. W rinses his mouth afterwards to complete the oral hygiene activity. So take a look at all the tasks involved in this activity and then determine the amount of assistance that were required. That is key when you're looking at something. Think about all the activities that are required and then think about the amount of assistance that's needed. So how are you going to answer and code this? Will it be code 04, supervision, touching assistance? Will it be code 03, partial moderate assistance? Will it be code 02, substantial maximal assistance? Or will it be 01, dependent? So let's think about that, talk amongst yourselves, figure out all the different tasks involved to help you determine how you would code this. Okay, I think we've got everybody in. Much better. 86% said that it was B. Let's take a look at the correct answer, which in fact was B. And we still have about 7% for supervision, touching assistance, and we still have another 7% who thought it was 02, which would have meant that the helper did more than half the effort. But in fact, in this case, when you look at all the tasks, it should have been coded 03 because the helper did less than half the effort. And what is our rationale? I think we're low battery here on the advancer. There we go. So again, the oral hygiene would be coded 03. Partial moderate assist, and our rationale is the provider helped less than half the effort of the oral hygiene activity. The patient cleans his lower gums and most of his upper gums and rinses his mouth. So that's more than 50% of the task, and so that meant that the helper assisted with less than half the effort. Okay. All right, so let's look at scenario 4. We have an occupational therapist, in this case, and a CNA who are being interviewed. This is an example of how you might go about interviewing and conducting a probing inquiry with your staff. If you, let's say, did not get a chance to see this patient, or you want to ensure that this is their baseline, so you would interview various clinicians who have worked with this patient. In this case, it was the OT and the CNA. So the OT who's doing the assessing asks, does Mrs. K need help when brushing her teeth? And the CNA says, yes, she needs help to clean her teeth. It doesn't give us a lot of information, right? We want to probe further. So the OT says, how much does she need to brush her help? Does she need to brush her teeth? And then the CNA gives us enough information. She says she usually gets tired after starting to brush her upper teeth. I have to brush most of her teeth. So that gives you a lot of information, right? And if you hadn't continued to probe and ask further information, you wouldn't get adequate amount. And so you continue with that probing, questioning to ensure you get all the information that you need. So for this one, how would you answer it? Would you code 04, supervision or touching assistance? Would you code 03, partial moderate assistance? Would you code 02, substantial and maximal assistance? Or 01, dependent? Let's see what you come up with an answer for this one. Very quick responding for this one. I think you guys nailed this one. Let's see. 96%. Excellent. Okay, still 4% said that it was partial moderate assist, but when that when the CNA indicated that in fact she did most of it, that was your big clue here in terms of which coding you would use. So our rationale was that the CNA provided more than half of the effort to complete Mrs. K's oral hygiene, and the OT determined the patient's performance based on a conversation with the CNA. And of course, that's a direct care staff member. So again, you can conduct those interviews. You can get more information from these key staff members and be able to get this. So again, by asking those probing questions, you can use a 01 to 06 code rather than an activity not attempted. If you hadn't seen how the patient had completed the task, and without going to further explore what other staff members, key staff members had observed, you may have wanted to put in a dash, which of course you want to avoid, where you're stating that you have no information. So this is an important distinction here in terms of how to ensure that you get accurate data and baseline information on your patients. So let's go through toileting hygiene. This applies at admission and planned discharge. Our definition has been clarified, so now it reads, for toileting hygiene, the ability to maintain perineal hygiene, adjust clothes before and after voiding or having a bowel movement, if managing an ostomy, include wiping the opening but not managing the equipment. So this is an important distinction here in terms of the types of activities, that we want to look at. So the coding tips for toileting hygiene focuses on clothing management and perineal and perianal hygiene. So toileting hygiene is coded if the patient uses a toilet, if the patient uses a commode, and even if the patient is incontinent, you would code toileting hygiene, and even if the patient completes bowel programs in bed. So this is important to keep in mind. We've had a number of help desk questions about this to clarify. So we want to ensure that we cover this. So let's do this last practice coding scenario before we take a 15-minute break. Mrs. T has a progressive neurological disease. She wears pull-up slacks and underwear. During toileting hygiene, Ms. T prefers to be assisted while standing in front of her bathroom sink. She steadies herself with one hand on a grab bar and she tries pulling down her slacks and underwear with the other hand, she needs assistance from the helper to complete this activity due to muscle weakness. Ms. T wipes her perineal area without assistance after urinating. After a bowel movement, the CNA, however, performs the perianal hygiene. The helper then pulls up Ms. T's underwear and slacks. So this is one that will take some discussion. Remember, we're talking about when we look at this item, we are looking at managing of clothing before, and also we're looking at the hygiene during. So let's look at it's the management of clothing and the hygiene. So how would you code GG0130C? You're going to code 4 for supervision or touching assistance, code 03 for partial moderate assistance, code 02 for substantial, or code 1 for dependent. Okay, let's see how you do. Remember, you got 3 toilet and hygiene tasks: managing clothing before, you've got the hygiene aspect, and you've got the managing clothes afterwards. Think that through. It looks like we've got 79% said C, which is the correct answer. 21% said B for partial moderate. So let's look at the rationale. And for this item, toileting hygiene, it would be coded 02 substantial and maximal assist. And why is that? The helper provided more than half the effort for the patient to complete those 3 toileting hygiene tasks of managing clothing before voiding or bowel movement, the perineal and perianal hygiene, and managing clothing after voiding or bowel movement. So we want you to note that the amount of assistance needed for toileting hygiene after a bowel movement is different. If it's different than the amount of assistance needed after voiding, urinating, then code based on the higher amount of assistance needed. Okay? Or we have just finished scenario 5. We're going to go ahead and start with wash upper body, which is GG0130D. So this is what it looks like. And we have not made any changes to GG0130D for wash upper body. So they will be the same between version 3.00 and V4.00. So again, just as a reminder, wash upper body was the ability to wash, rinse, and dry the face, hands, chest, and arms while sitting in a bed or chair. So again, those important tasks that are a part of the activity. Okay, so wash upper body may be assessed based on a sponge bath while sitting in a chair or bed. This also includes at the patient's bedside, at the sink, or in the shower or tub. Some patients, especially at admission, may not be able to bathe in the shower or in the bathtub, so when assessing washing upper body. For these patients, the clinician can assess the patient as he or she completes a sponge bath at bedside or at the sink, and the patient may sit in a chair if safe. The patient may also choose to stand at the sink during wash upper body. And here's what our self-care discharge goals look like. We're going to switch now to looking at those self-care discharge goals that are assessed during the admission, and you can see it's on the admission assessment. These are only completed, even though they are discharge goals, they are only completed on the admission assessment. So for our discharge goals, we want to consider the patient's prior self-care functioning. How did that patient perform prior to their admission? What is their current diagnoses? What are the expected various treatments that that patient will undergo that could affect the goal? And what is their actual motivation to improve? We have some patients who are highly motivated and some who may not be. That should be a consideration in terms of establishing your goal. And then anticipating the length of stay, how much time will you have in terms of administering therapeutic activities for them, and also their medical prognosis is very important. You, of course, discuss these types of things with the patient, perhaps their families as well, to determine what the collaborative goal would be. So again, we're going to go through these discharge coding tips. A licensed clinician can establish these patient discharge goals at the time of admission, and of course it's based on the patient, all of the factors that we just talked about. Those are important factors to consider. The goals should be established as part of the patient's care plan, and one goal must be indicated, must be coded for either self-care or mobility. So at least one must be coded. So you'll be coding the discharge goals using that 6-point scale. The use of activity not attempted codes 0907, you likely again won't use 10, or 88 is permissible. That's a change to code discharge goals. For the LTCH QRP, a minimum, again, of one self-care or mobility goal must be coded. And then using the dash is allowed in this instance. So if you've coded all the goals that you have intended to, then those that you don't intend to code, you may use a dash in this assistance, and it does not affect your APU determination. So in this instance, it does not affect your APU determination. So if the admission performance of an activity was coded 88 not attempted due to medical condition or safety concerns during the admission assessment, a discharge goal may be substituted or submitted rather. It may be submitted using that 6-point goal. So if you have a patient who did not perform the activity, it wasn't safe for them to do it at admission, but you project that that patient will likely be able to perform that activity at some point, and you project the goal based upon what we just talked about in terms of criteria, that's what you could place into the discharge goal placement. So that's the 6-point scale that you would use for that discharge goal. If the patient is in the LTCH for less than 3 calendar days, code a minimum of one self-care or one mobility goal per patient stay in the self-care or mobility discharge goal to the best of your ability. So if that person, you didn't get a chance to see that person much at all, but you did project what that person might do in terms of a goal, just place at least one and base it upon your best judgment in terms of the predicted care plan that you would have had for that patient had they not left. So let's take a look at the discharge goal examples that we have, because some clinicians or providers may not be aware of this factor in terms of, and you may be basing your decision in terms of discharge goals only based upon that the discharge goal would be higher than the admission performance, but as you'll see that that's not the case, and we've given you some good examples here to illustrate that. So in this case, it's the traditional discharge goal code is higher than the admission performance code. Most people are familiar with that. So in this case, oral hygiene admission performance, example is Mr. M prefers to brush his own teeth, but at admission he needs help with more than half the effort due to the upper extremity weakness that he's experiencing. And then for coding, the clinician assesses Mr. M's admission performance for oral hygiene and codes Mr. M's admission performance as 0 to substantial maximal assistance. If the clinician determines that the patient is expected to make gains in function by discharge, then the code is reported for the discharge goal, and of course it will be higher than the admission. Okay, so then we have also a discharge goal that is higher than the admission performance goal. In this case, we're just going to go ahead to the discharge goal. In this case, is the same as admission performance. So I don't think you need more than one example for that. In this case, the discharge goal is the same as the admission performance. So when would that happen? In this scenario, Mrs. T had severe tremors due to Parkinson's disease. This condition was resulted in multiple activity limitations. The clinician observes Mrs. T's admission performance and discusses her usual performance with Mrs. T and her family to determine the necessary interventions for skilled therapy. The goal of care is to maintain her self-care skills using the clinician. So the clinician codes Mrs. T's admission performance as 0 to substantial maximal assistance. So due to Mrs. T's progressive and degenerative condition of Parkinson's disease, the clinician and the patient believe that Mrs. T is not expected to make gains in her eating ability and maintaining her function at the same level, and it is desirable for her to maintain that same level of function and achieve this as her discharge goal. So the coding for this, the clinician anticipates that Mrs. T's discharge performance would be 0 to substantial maximal assistance. Okay, and now we have a discharge goal code that is lower than the admission performance code. And some clinicians may not be familiar with it, that is acceptable. And with your population, of course, you hope to see gains, but sometimes it's just not possible. So here's an example of that. Toileting hygiene admission performance. Mrs. M has a progressive neurological illness. Although her participation in skilled therapy is expected to slow the pace of her anticipated functional deterioration, it is not anticipated that her performance in toileting hygiene can remain the same. The patient's discharge goal code will be lower than the admission performance code, and Mrs. M prefers to use a bedside commode for as long as possible rather than using incontinence undergarments. So the coding, in this case, the clinician codes her admission performance as her present status, which is 03, partial moderate assistance. However, for the discharge goal, by discharge, it's anticipated that the helper will assist Mrs. M with toileting hygiene by performing more than half the effort. So in this case, coding this item, the clinician codes Mrs. M's discharge goal as 0 to substantial maximal assistance. So the clinician determined that the patient with this progressive neurological condition is expected to decline, and in this scenario, the discharge goal is lower than her admission performance code. So let's move on to the mobility section, GG0170. So we're done with our goals section, and now we're going to turn to the next section for the performance status. So self-care and mobility activities are to be coded according to the patient's need for assistance to perform the activity safely. The word safely was removed, we want to point out, for several of the items under mobility's item set, and it's not because safety is not important, it's just that we had stated the word safely in the general coding instructions. So that is why we've chosen to remove it. It's just less burdensome in terms of extra words, but we want to state again, of course, that safety is incredibly important. It's a primary consideration for our patients. So here's what the mobility items from GG0170 look like. This is what they look like. They apply to the admission assessment, and you'll see this is how they're laid out. And then this is how you will see them appearing in your LTCH CARE Data Set for the planned discharge assessment. So let's go over the steps for assessment. For assessing GG0170 items, they're pretty much the same as the steps as assessing the self-care items. So we'll just go through these rather quickly. So again, it's the licensed clinician that we're looking for in terms of assessing the patient's performance and through direct observation. Again, you can get further information from other care staff and family during that 3-day assessment period. And again, it's anticipated that a multidisciplinary team is going to feed into that information, or you will be conducting probing questions to get that information. Again, patients should be allowed to perform these activities as independently as possible, so that if it means that that person is safer using the mobility device that they had been using, you would assess them with that rather than putting them at risk to perform something without a device or in a more dependent mode with you providing the physical assistance. If it's unsafe or if it's poor quality, you have to step in and give them the amount of assistance that's required for those mobility activities. These activities may be completed with or without the assistive device, as we talked about. The patient's mobility performance may vary during the assessment period, but we want you to report the patient's usual status, not the patient's most independent and not the most dependent. So this is where your clinical judgment comes into being, that you have to determine what is the usual status for that patient. Again, it should be assessed prior to any benefit from therapy. It's important to ensure that that happens, and of course you'll be referring again to facility, federal, and state policies and procedures to determine which staff may complete the assessment. Again, assessments are to be done in compliance with the federal and state and facility requirements. So we have our codes that we've already gone through, so we won't go through these again. The 6-point codes are 06, 05, 04, 03, 02, 01, and we'll have opportunities to use these codes, as well as we've reviewed what coding you'll be using if the activity did not take place. Additional coding tips. Again, we've reviewed this in terms of what we mean by the 3-day period. I'll just kind of go over these quickly because we've already gone through these in the self-care section. And again, emphasis on that multidisciplinary team. And this is worth discussing. So perhaps the patient only walked twice during that 3-day assessment period, and it was not in therapy, but instead on the unit. So again, using that multidisciplinary approach in communication about the patient with those probing conversations with other staff will help you make that final determination about the patient's admission functional status. So it's important for you to communicate with your other staff, and then we've talked about the dash already. The dash sign means no information, and CMS expects this to be used rarely, and the use of dash for items necessary may result in the 2% payment reduction for the LTCH's annual payment update the APU. So again, do not use the dash if the reason that you did not code the item was because the activity was not attempted. Use those activity not attempted codes rather than using that dash. The dash, however, can be used for GG0130 discharge goal items. Remember, we talked about that. As long as you've coded at least one self-care or one mobility item, then it is acceptable to use the dash in this case, and it does not affect your APU determination. On the admission assessment, you're going to code again the usual performance. You're not looking at the best performance, you're looking at the usual performance, and you're assessing and coding what actually happens with the patient rather than what you think that patient is capable of. An activity can be completed with or without a device. We've talked about this. And the helper, if the helper needs to retrieve the device, then again, that would be a setup or cleanup. The helper is not expected or to be with that patient during the activity itself when you're using the setup or cleanup. Remember that's only happening, the assistance happens before or after the activity, not anytime during the activity. For unplanned discharges, if the patient dies while they're at the LTCH, again, we talked about this in light of the self-care, and the same applies for the mobility items, that the section GG items are not included in the unplanned discharge assessment, and they're not included in the expired assessment. Okay. So again, the instructions refer to safe performance, which applies to all self-care and mobility items. So again, we have not repeated the word safely, although we do acknowledge that safely is paramount. Okay, so here are beginning of the mobility item set. So you can see them listed here. We're first going to go through GG0130 roll left and right. So the definition of roll left and right has been clarified. We've emphasized on the bed because of questions that we've received from providers like you in terms of where can this take place, because sometimes this assessment of rolling left to right might take place in the therapy gym. Maybe the patient is on a mat. Maybe the patient is in a reclining chair. So we wanted to ensure that you folks are clear that the ability to roll from lying on back to left and right side and returning to the back, those are all those different tasks that you have to look at and combine when making that decision as to what the level of assistance needed is. And those all have to happen on the bed. Okay, so let's practice this. Let's look at coding scenario 6. Everyone have their clickers and the designated person through which we will get that information. Okay. So, Mr. R experienced a stroke and is obese. The nurse instructs him to turn onto his right side, providing step-by-step instructions to use the bed rail, bend his left knee, and then roll onto his right side. The nurse asks another staff member for assistance. The patient places his hand on the bed rail and provides a small amount of help as the two nurses roll him onto his right side. Next, the patient is instructed to return to lying on his back, which he cannot complete, and the clinicians provide the necessary assistance. Mr. R then requires physical assistance from the nurse to roll onto his left side and to return to lying on his back in the bed to complete the activity. So, think about this, all of the different elements. Think about who's helping, how many people are helping, what the patient did, and then make your decision what it is how it is that you would code this. So how would you code this item? Would you code it 04, 03, 02, or 01? I'll let you think about that. Okay. Looks like we've got just about everybody. And it looks like 60% of you said C, substantial maximal assist. 40% of you said D. Yet the answer here was D. So I think I can guess why 60% had said what they did. So maybe this rationale, and we'll talk about it further, explains this. So the rationale in terms of rolling left and right would be coded dependent because although the patient, and we talked a little bit about this before, if they even provide a modicum, a small amount of assistance, if you've got two helpers, automatically it is going to be dependent. Automatically. Even if he does something for himself, but you need two helpers for him to complete the activity, it must be coded 01. I think that's a great teaching moment too for your staff, right? So you can use these with your staff in terms of further explaining what the requirements here are. So let's look at sit to line. And this applies at admission and planned discharge assessment. This is the second item on your mobility item. So there's been no changes to this item of sit to line, the ability to move from sitting on side of bed to lying flat on the bed. So there'll be no changes between your versions. So let's skip that one right on to lying to sitting on the side of the bed. And we see that, again, this applies to admission and planned discharge assessment. So let's take a look at the coding changes for this one. So this one refers to safe performance. The coding instructions in general refer to safe performance, which applies to all self-care and mobility items. So we have not repeated the word safely. That's the only change that we've made here. Otherwise, the definition is the same. Lying to sitting on the side of the bed, the ability to move from lying to the back to sitting on the side of the bed with feet flat on the floor and with no back support. So again, we acknowledge that safety, patient safety is always a primary consideration. Let's look at coding scenario 7. Ms. P has a chronic respiratory condition and swallowing disorder due to a recent stroke. The medical order requires the head of her bed be slightly elevated and serves as the lying position required for Ms. P. Sounds like a lot of your patients, right? So to transition Ms. P from lying to sitting position, the CNA lifts and swivels Ms. P's legs over the edge of the bed while supporting and lifting her trunk. Ms. P assists with scooting herself toward the edge of the bed and balances herself while sitting at the edge of the bed with her feet on the floor. So how would you code this? Code 04, supervision or touching assistance. Would you code 03, partial moderate assistance? Would you code 02, substantial maximal assistance? Or would you code 01, dependent? See what your answers are. Okay, so you want to think about this one. I hear lots of talk and discussion. That's good. So, okay, so it looks like 77% of you said C, code 02, substantial maximal assist. And 23% of you said code 03, partial moderate assist. So it's taking all the tasks that are part of this activity and determining how much assistance. And 77% were correct. And let's take a look at the rationale. Coding of GG0130 lying to sitting on the side of the bed would be coded 02 substantial maximal assist. The rationale is the helper completed more than half the effort in transitioning the patient from lying to sitting on the side of the bed. Note, if the clinician determines, and this is an important sidebar in terms of you folks with patients who need this elevated head of the bed, that if the clinician determines that a patient's medical need requires the patient to sit in an upright position, that's a fully upright position, rather than a slight elevated position, then code the activities for GG0170B, lying to sitting, and GG017C, lying to sitting on the side of the bed. So sit to lying and lying to sitting should be coded in that case where a patient cannot tolerate even in just a slight elevated position, but if they have to have an upright position of sitting because of medical conditions and safety, that you would code that person 88, not attempted, due to medical or safety conditions. Okay, let's look at the next item, which is sit to stand. And for this one, it's applied to admission and planning discharge assessments. This is where it lies. It's the fourth item. So what are the changes we made to GG017D? We have applied the instructions to refer to safety performance and to all self-care and mobility items, so we do not repeat that word safely in individual items and definitions. The definition of GG0170D, sit to stand, has been clarified, and the ability to come to a standing position from sitting in a chair, we've included wheelchair, since that's commonly where you find a patient who's mobilizing themselves that way, or on the side of the bed. So for this item, we have added the word wheelchair. Let's take a practice coding here, and let's take a look at coding the scenario. Number 8, Mr. M has severe emphysema and pneumonia. The nurse reminds him to lock his brakes and swing his leg rests aside before standing up. Mr. M places his hands on the wheelchair armrests and he attempts to stand, but struggles with labored breathing and weakness. The nurse uses a gait belt to assist Mr. M as he starts to rise from sitting to a standing position, and Mr. M completes the activity by supporting himself. So let's see what we have as our choices for coding. Code 04, supervision or touching assistance. Code 03, partial or moderate assistance. Code 02, substantial maximal assist. Or code 01, dependent. So what are you going to choose for this one? Again, considering all the parts of the activity to determine what you would code. Okay. Let's see what we got here. So 63% said B, which is correct. 19% said A, supervision or touching, and 19% said C, code 02. So our rationale here is that the helper provided less than half the effort by providing initial weightlifting assistance, but he did the rest of it himself. So that would be partial or moderate assist. So the chair bed to chair transfer is our next item on the mobility grouping. The coding instructions, again, we've taken out the word safely because we imply that in our general coding instructions. Of course, you would ensure that this was done safely. No other changes to that item. Toilet transfer is next. And again, the word safely was removed only because it appears in the general instructions, and toilet transfer is the ability to get on and off a toilet or commode. So let's take a look at that. All right, so Mr. F has no urine output due to chronic renal failure, and he uses a bedpan for bowel movements. At this time, he does not transfer onto a toilet or commode, but his discharge goal is to transfer onto the toilet with steadying assistance from a helper, which is the same level of assistance he needed for his activity prior to the current episode of care. How would you code this? 02, substantial max assist. Code 09, not applicable. Code 10, not attempted due to environmental limitations. Code 88, not attempted due to medical condition or safety concerns. A minute to check that. Okay, you're thinking about this one. Okay. See if we can get a few more responses here before we look at the answer. Okay. Let's take a look. 63% said D, code 88, not attempted due to medical condition or safety concerns. We had 21% 09s, and we also had 16% of 02s. And 88 was the correct answer. So coding the toilet transfer 88, not attempted due to medical condition or safety concerns, was the correct answer because the patient does not transfer on or off the toilet at the time of assessment. And prior to the episode of care, he did transfer on and off. So that's the distinguishing feature. Again, there was a new condition that he had, and so that use of 88 in this case was what we were looking for. If the patient did not attempt to perform the activity and did not perform the activity prior to the current illness or exacerbation or injury, then he would have been coded 09, not applicable. So those are very important codes to train on and to ensure that your staff understand. So let's look at walk 10 feet and how we've changed this. So this is a change that represents us having taken the gateway question, does the patient walk, which was GG0170H1 admission and GG070H3 planned discharge. Those have been removed because we want you to go right ahead and answer if the patient for GG0170 walk 10 feet, it includes a skip pattern, or if the activity did not occur. So if you say that the activity did not occur, when you answer, did the patient walk 10 feet, then you will be instructed to skip the additional walking items, and you'll go right to wheelchair. So that represents some feedback we got from you folks in terms of saving some time. So again, it's if you code any of the does not occur items, then you will be skipping that item, and you'll be instructed to, if you do, however, answer with a 06 through 01, then you will go to the next walking item. So let's look at the scenario. Mrs. C has not walked during the past 3 weeks due to her recent leg weakness and fatigue. The physical therapist determined that it is unsafe or Mrs. C to use a walker at the time of admission and works with Mrs. C to walk using the parallel bars during therapy. So let's see how you would score for this. Would it be 01 dependent? Would it be 09 not applicable, 10, or would it be code 88 not attempted due to medical condition or safety concern? So how would you code on this one? Okay, it looks like we've got a good number. Let's check this out. 100%. You got it. Nailed it. Very good. That was excellent. And in this case, this patient did not walk. So if we look at coding this, the rationale, we also considered, and I wasn't sure if you folks were going to notice that, but you did, that walking in parallel bars is not considered when coding the GG0170 walking items because it is equipment that's not portable. So if the patient was unable to walk without the use of parallel bars, code the reason the activity was not attempted. In this example, the activity wasn't attempted because of medical conditions or safety concerns, and use of those activity was not attempted codes will result in a skip pattern, and the patient does, and you'll go right to, does the patient use a wheelchair or scooter? So a discharge goal for any of these items that were skipped can be entered if a discharge goal is identified. So that's a very important concept, that if you are asked to skip out of the walking items, you can still enter a discharge goal for those items. So remember that. Next, we're going to go to walk 50 feet with 2 turns, and no changes for this item has been enacted. Walk 50 feet with 2 turns, 1 standing. The ability to walk 50 feet and make 2 turns remains the same. Let's go right to the practice scenario. When Mrs. B was admitted to the LTCH for therapy, she walked using parallel bars during her session with PT. Ms. B's therapist determined that it was not safe for her to use a walker at the time of admission. Ms. B had progressed in therapy. Upon discharge, Ms. B walked 50 feet with 2 turns using a walker while her therapist provides steadying, touching assistance once per day. On the LTCH unit, Mrs. B used her walker when ambulating once in the morning and a few more times in the afternoon, and needs more support due to fatigue. So on the unit, a nurse provides trunk support assistance. The nurse provides less than half the effort. And when Mrs. B walks 50 feet with 2 turns using her walker. So consider all this information, and would you say that it was supervision or touching, 04, 03, partial moderate assist, 02, substantial, maximal assist, or 01, dependent? So let's take a look at what you decide on this one. Okay, we got lots of answers, so let's check this out. 83% of you said B, code 3, partial moderate assist, and that is correct. So Mrs. B a need for assistance when walking 50 feet with 2 turns varies at the time of discharge. And when Mrs. B walks 50 feet with 2 turns, she usually needs trunk support, and that nurse was providing less than half the effort. So excellent. Walk 150 feet is the last item. There were no changes made to this one. And also we have the wheelchair items. And we've got GG0170 Q1 and Q3. Does the patient use a wheelchair and/or scooter? So we've just added the and/or scooter for you in terms of those. No changes were made in terms of GG0170R. And again, the type of wheelchair or scooter used, and wheel 150 feet. No changes were made here for the wheel 150 feet. It applies to both admission and discharge items. And mobility discharge goals, it's the same considerations in terms of discharge goals. Again, we've stated that you can make discharge goals even if you have applied activity did not attempt with these items. That might be more the norm for you folks in LTCH, so just pay attention to that. That's an important consideration with your population, is to make those goals when you intend to for those patients who maybe are not completing those activities at admission, but you want to insert a goal for them in terms of a discharge goal. And again, with those mobility items, that may be more of the case with you folks. But, you know, check around, making sure that you captured all of the information that you had access to on the floor, on the unit. It doesn't all happen in therapy, so ensure that you can, when you can, assess the patient with a 06 through 01 goal. So in summary, we want to say that Section GG includes items that assess the need for assistance and self-care and mobility, and we've presented to you all of the different changes that we've made, which really shouldn't change the coding for version 3.0 through version 4.00. It's more clarifying language that we went through, and the coding instructions that we've talked about. Those are needed for information and understanding those items. Use those coding scenarios with your staff as part of your action plan. You've got a lot of coding opportunities here with the scenarios we provided, and we do see that there was variability in terms of the coding. So it's up to you folks in terms of your action plan to really assess what your staff needs are in terms of understanding the codes and understanding the items and how to code them. We want to get as accurate information as possible, and to achieve that, going through whatever your plan is in terms of your action plan to practice with your staff, these coding techniques would be advisable. So we applaud you folks in terms of the great care that you deliver to your very, very ill population. Making sure that you educate your staff, of course, is paramount, and we leave that to your good judgment in terms of the work that you do. So thank you so much.